started. I know that we are going to have, I believe the Senate is still in session, and I know that we'll have some people coming in and out throughout the day. My name is Kathy Judge Cardillo. I am Director of Advocacy for Trinity Health in Pennsylvania. I want to thank everyone for joining us today in a dialogue on an issue that's deeply impacting families and communities across Pennsylvania. We hope you leave here today by the collective wisdom, passion, and expertise and commitment of our leaders and our communities, as well as a greater understanding of the best practices and policy solutions that will help prevent and combat the devastating epidemic. As part of Trinity Health, one of the largest Catholic healthcare delivery systems in the nation, serving more than 30 million people across 22 states, we at Pittsburgh Mercy Health System, St. Mary's Medical Center, know that our Trinity Health colleagues in communities across the country are hurting because of opioids, just like all of us in Pennsylvania. This national perspective brings an important lens to our public policy work on opioids. Our mission truly drives our vision and strategy to be a compassionate and transforming healing presence in our communities. Reverence, honoring the sacredness and dignity of every person in a core value guiding our policy developments on reducing opioid harm. For over a year, more than 200 clinical leaders across Trinity Health, from Fresco, California to right here in Pennsylvania, have been coming together in an advancement of opioid stewardship, opioid education, patient-shared decision-making, and advocacy to reduce opioid harm. Coming together as a system, we developed the comprehensive policy recommendations that are before you today. We believe these actions, collectively, are imperative to reducing opioid harm, promoting people-centered care, and honoring the sacredness and dignity of every person. That's why leaders across Trinity Health are sharing these recommendations with federal, state, and local policymakers as we are here today. These recommendations urge coordinated, comprehensive solutions across local, state, and federal levels of government, including financial support. They prioritize a whole person approach to meet the full range of individuals' physical, behavior, and social service support to meet social service to an integrated fashion. Our recommendations call for prevention through communication, transparency, and accountability among all stakeholders, and call on policymakers to help break down transparency across accountability among all stakeholders, and call for, I repeated that, okay, so let me just say that sentence again. Through communication, transparency, and accountability among all stakeholders, and call for policymakers to help break down barriers to effective treatment and recovery, including reducing stigma. We look forward to this afternoon's sharing and dialogue on how best practices align with these actions for policymakers, and thank you for committing the time here today. So our program today, we have 5 different presentations, and I am delighted to have Dr. Michael Consuelos from the Hospital Association with us today to facilitate our panel discussion. The format will be, we will have each presentation followed by a 5-minute question and answer, and then we'll move on, and then at the end, because we recognize some leaders might be coming in and out, we'll have a more robust dialogue for us. Dr. Consuelos has served as Senior Vice President for Clinical Integration for the Hospital Association of Pennsylvania. Dr. Consuelos works with members of hospitals and healthcare systems, as well as stakeholders, to promote innovation ways of improving healthcare delivery. Through his engagement with physician leadership, supports hospitals and healthcare systems in developing new payment models, works to improve quality of clinical care, and supports integration across the continuum. He encourages sharing of best practices and involvement through leadership to strengthen hospital-physician relationships. He has held multiple physician leadership positions encompassing physician practiced pediatric service lines since 1977.
I'm old, but
All right, I can see the numbers, thank you. He has extensive experience leading healthcare capital planning, strategic business ventures, physician comprehensive plans, and community pandemic response. He has coached physicians and lectured on various leadership competencies. You sure? I just want to say you're from Princeton, and more importantly, you got your medical degree from the University of Pennsylvania. So I think that's important. And please welcome me, and please help me welcome Dr. Gonzalez.
I'll keep my comments short because I think the most important part of today's meeting is the folks who are speaking after me and the more interactive question and answering. It's a couple things that I kind of want to put on the table is that obviously we have the predominance of the conversations are going to be from healthcare providers, folks in the healthcare or along the continuum of care, folks in the community from their perspective. And that's one of many, many lenses that you can see this problem through, right? But I think it's important that we see it as a medical problem, as a brain disorder, that opioid addiction or opioid use disorder, really in our eyes, it's not a legal issue primarily, it's not a moral issue primarily, it's really a brain problem. And how do we treat brain problems with evidence-based medicine, evidence-based practices? And it's also a chronic condition. I think that if we think about opioid use disorder like we do diabetes, or just heart failure, obesity, other areas of health that's creating large problems in our communities, and we look at the same way looking at this problem, I think many of our perspectives will change. And hopefully through today's conversations, that some of that will occur as we think about policy implications to help address this important epidemic in our communities. The other thing I want to mention is that it's not like today or yesterday or the year before was the first time we heard about opioid addiction. This has been a long-standing problem, not just in the United States, but across the world. It's just that for many, many years, it was something that we did not openly talk about in our communities. It affected certain groups, certain other people in our community, or mainly urban areas. And this killer has really gone across all socioeconomic, all community, all levels. It doesn't know, doesn't care who you are, who you were, where you went to school, who your parents were. All of us are basically primed to have an opioid addiction at some level. So I think we need to think about that it is a chronic brain condition, and we need to think about very, very strongly is how do we work together to battle this issue that will be with us for a very long time. So thank you for coming today, and I look forward to today's presenters. Great. All right, so we're going to have our first presenters, I guess. So we have a couple of folks from the Be Proud Foundation Step Up, including Jane Buchanan, who's the founder and director of the Be Proud Foundation, also Sam Williams, who's a board member and former client and current professor at the Lincoln University. And we also have some student representatives who I think are really the most important part of the conversation. So without further ado.
Thank you very much. We were fortunate enough to get funding through the Department of Labor, employment and training programs to provide the Step Up program. And the Step Up program works with low-income students from Upper Darby High School. We have 14 in the program. 2 are here to represent today, and they are awesome because all the other ones are at graduation practice. So a part of our program was to, in the summer, provide training in mobile app development. And that's where Best Core came in here, Dr. Sam Williams, who teaches this as a college level course. So he came in and worked with the students, and this is the result of that. So I'm going to pass on to the next person.
to this epidemic. And we believe that one of the greatest ways to do that is to prevent it from ever happening. So we created this app to educate students on the substances that are causing all of these addictions that affect so many people around us. So we're going to educate so we can prevent that from happening. And it's available on our Android software. It's not yet available on iOS, but right now it's available on Android. It's available to all students our ages. Since we all use our phones a lot, we can always have something to look at and educate us and something to turn to when we need help.
And it also provides news from the school. If you can connect at the school that you go to as well, and you can get news from the school or that area that you're around to help you as well.
Okay, one of the House bills, as you can see on our slide, 1190, is to hopefully create a school-based substance abuse prevention and intervention program. And we feel as though it's really important. One of the pieces of our act is it's students talking to students. So it's really important that if that occurs, that yes, we do need the medical information, absolutely, but it needs to be focused on the students at that level.
And because we're appealing to students our age and all people of this younger children and students, maybe older students too, of this generation, we created a way that would keep them intact and want to be always looking at this app and involved in this app. So we created a news feed which would, unlike most news today, provide a lot of positive things that are going on locally so that they can stay involved and away from the negative impact of opioids and other substances.
And as you can see, House Bill 1984, it gets very specific in focusing on grades 6 to 12. And one of the things that we know about students in grades 6 to 12 is many of them live in their homes, much to our dismay. So we feel that this kind of technology makes sense for them, that it's something that they're going to be very comfortable with and would fit very well with this House bill. As well as Senate Bill 1013 that enhances substance abuse prevention education in schools. That the children know in advance what harm can occur from using these substances so that they avoid doing so.
And so a part of the educating part of allowing students to be educated about why these substances aren't good for them, because a lot of them don't really know the harmful effects that they can have to them. And they hear from around everyone that, oh, maybe this is okay. Oh, this isn't as harmful as the other thing. But we have here is a list of all the things that people abuse and how it actually does harm your body, instead of listening to what your friends say because they are not educated on what it does.
And our hope is also that if someone who is already using could see the facts and realize that the drugs or the substances that they are using is something that they shouldn't do instead if they had already started.
Very important is Senate Bill 654, Drug Overdose Good Samaritan Law Amendment. One of the problems with overdosing and resulting in death is because people delay making a call to seek medical help or any sort of help. And so we need to educate people and students on the importance of making that call right away. And one of the very cool features of this app is that when you download it, you are input your emergency contact information, which allows you to then, if you are in a situation where maybe a friend isn't doing well and they don't look so good, or you're having a problem, that they can push the emergency button, and that will send an emergency alert to their emergency contact person. And it will give them an exact GPS point and directions to get to that person. So I know as a parent, that's really, to me, very important. If a child is to get into a bad situation of any kind, they could be getting kidnapped. I mean, we're well beyond the abuse of alcohol or drugs, that they know they can push that button and somebody knows exactly where they are and can come to their aid. And there's 3 choices, so they can actually put 3 different contacts in there.
So this button that we created, we thought it would be a great idea because students are often afraid to get involved because they do not want the punishment, or they feel like they will get in trouble for helping out because of the things that they've been doing, and they know that it's illegal and they know that they should be doing it. So they say, oh, let me not help my friend, or maybe they can get through it because there will be consequences. But what this does is it allows students to be involved in the situation and help them out because they no longer are afraid to send for help. They can click this button and they know that someone will come and not be there to give punishment, but there to help.
That's the rest of the students that actually
We really want to thank you for your time.
Before we thank you for your time, I want to just take an opportunity and just kind of summarize what's going on. There's an app that is created. In that app, there's information that students are not privy to, or they don't seek out themselves. That information is there. So it spans from having the data and a way to combat peer pressure. Marijuana is good for you. There's nothing wrong with smoking marijuana. There's nothing wrong with ecstasy. Here in this app, you have information that tells you that it is. So even when a friend says there's something wrong with this, you say, no, there is something wrong with this. I see what this can actually do. And have that function also. In addition to that, the beacon is probably one of the most important aspects of this app. The ability to hit a button and send out the people that will actually come and help you in the process. And these are people of your choosing that will actually come and help you. And if an ambulance thing you call it's an emergency issue, that can happen also. That can be actually programmed also. So there's several functions for this app, and it's actually helpful. As working as a school psychologist, I'm on the front line dealing with students who are on their way to being addicted to a serious hardcore drugs. And I'm working in drug and alcohol for many years, listening to the stories of adults, working as a counselor. I hear when this addiction starts. I hear the family issues that contribute to these addictive habits. So it's like the first line of defense that we can use. One tool of many.
And in addition to that, if somebody who has been like through drug and alcohol rehab or so forth, one of their emergency contacts could also be their sponsor.
Thank you for your time.
Thank you so much.
So this is the time where it's the most interesting part, right? So hopefully we have some questions from folks in the audience.
Does that mean it's great?
Please come up to the table. Sit.
So if no one in the audience, does anybody, any other speakers have a question?
I have a question the app's free?
Yes.
Can anybody?
Yes.
And is it available to, you said other schools, or is it just the two?
Yeah, it has a function on it where you can say manage your schools, and if you click it, well, say school district, then it'll drop down to schools. So if you go to Upper Darby High School, you can just put in your school. And if you go to Chester High School, you can put in that school. And it also, not only do it give the beacons a location, it goes out to 3 people, and each of them will go, 3 people will come find out exactly and make it phone and both people, not 2 inebriated, so you can tell them the location. And what else?
Well, the app is fully functional. I mean, you can give a demonstration of the app now. As a matter of fact, it's very accurate. Like if one walked out into the hallway here and just went out to the front of the building, and that was the area, push the beacon, and it would just give you the directions.
So while we're going to do a quick demonstration, how many students are on the app already? Say, how many students are on the app right now?
We haven't launched it.
Oh, we haven't launched it. This is all pre-launch.
Yes.
All right.
And how are they being made aware of it?
We have a marketing team. She just let me know when she's having a situation, pull it down, accessible use fact, and gives me a location. Or I could, oh, here's a call button, I could call her. Are you okay? Are you okay?
Oh, yeah, got
And,
it.
right, it's in 2 months now. So not to
I think it's a great idea, and this is just for schools specifically. I mean, can it go to rehab centers? Can it go to Intermount? All these other.
It's another app being developed for that. It's like literally as we speak now. It's just that this was dedicated to schools. We know we can't mix them, like adults with the students. I don't think we can do that. So we have to make it different.
Don't want to.
Yeah.
Just a comment that I think that hitherto, this technology has been a great tool in people getting on drugs, to summon their drug dealer, to find out. I have a child who, in the dormitories, tells me there's an app where you can immediately find out who's got Adderall, who's got alcohol, who's got cocaine in the dormitory, who's got it in this big, huge dormitory. The brilliance of this is an app to actually help people get, find help for these kind of things. But this is a big tool that people use to be able to get whatever they want. So we're using this technology in an appropriate way. That's brilliant.
I definitely agree with you, and I also feel like it has to do with people being comfortable as well. People are more comfortable with phones and would prefer to use an app over actually picking up the phone and calling someone.
Right, we're finding a drug by going on the street and starting to talk to people. Do you have something? Do you have something? They'll get on their phone and say, hey, where's, and they'll get it really quickly. Now they can get help quickly too. So.
And it touches on every bill that any other questions?
Thank you so much.
So, no, I think the students have to leave. You have to leave now?
Yes,
Okay,
yes.
well, I personally, on behalf of Trinity Health, want to thank you for making the trip up here today, and we'll make sure that if any of the elected officials that come in, and the staff, if you have any additional questions, get in contact. We look forward to the launch of this. It does not have to be. I want to thank you for coming up today. So we're not scooting off just to go out and get more Penn State ice cream. They do need to.
That's okay though.
Yeah, thank you. Yeah. But yeah, safe travels and thank you. Brad, why don't you move up?
So, while Dr. Brad Gudetsky gets ready for the next presentation, he is the chair of the Mercy Health System Utilization Task Force or Committee, and his other real job is, obviously being an emergency medicine medical director at the emergency department at Mercy Fitzgerald Hospital. And I think that many of us will agree that emergency medicine physicians really are the front lines in many ways of this problem. And so he will be talking about the work that they're doing in his organization, but also across the Mercy system.
Thank you very much. Well, I think it's I'd like to thank Dr. Criswell for his initial statements. I can't agree with the theme of what he talked about this not being this is a brain problem. This is not a failure of morale or of determination. This is something that affects everyone in our society. And my job as an emergency medicine physician really allows me to interface with what ends up being the failures of all this good work that we all do. And over the time that I've been involved with this project and working with our system to try and come up with solutions to how we as medical professionals can really help people, how we can organize all the resources that are there, I do that on one end, and then I go back to work and realize that every day there are profound failures in what we are doing. So my presentation is one where I really just hope to outline the work that we have done within the hospital, within our health system, and then again sort of talk about where someone working in the emergency department sees the opportunities to say, these are things we're doing well with the help of everyone, with all the contributions we've had, but here's how far we have to go. And so I really appreciate this opportunity to be collaborative with everyone, because this, again, from working in the emergency department, this is what we want so much. We want the payers and the outpatient resources and the families to all be coordinated doing the same thing. And so much of the work that everyone's doing, although in a very narrow scope, is very good, it's not enough. And again, hopefully this will be a little bit of an overview of how we've approached this so far, and then talk about what I see as an opportunity. So Kathy had talked about Trinity Health. Trinity Health is a huge health system. I am representing sort of our local health system, but the work that I do is in collaboration with our system office, which has hospitals and provides care across the country. This is our general Trinity initiative, and again, not to kind of to read through, but the support that we give for the reduction of opiate utilization is sort of summarized here. We're already doing this. Most places are doing this. The 7-day limit for prescriptions in most cases, and and again, part of the issue with this is not to be so strict that it doesn't allow for some discretion. In general, we already have a part of our population who are already on opiates and there's a need for opiates in certain circumstances. But we're hoping on one end now is to prevent patients from getting to the point where they're dependent on them. And I think this has been a steep learning curve for all of us. I think our approach to emergency medicine was somewhat ahead of the curve, where we would resist these long prescriptions, and I think our experience now is kind of filtering into all the specialties. So, but we support optimizing the PDMP, which is a great tool for us. The ability to see what a patient's prescription history is, and to really structure their pain management from that is a huge tool. So the support of the support that we've got, the collaboration between states, especially where I work, living on a border between New Jersey, Pennsylvania, and Delaware, having the states collaborate and allowing access to this is a huge tool for us. And of course, we are following, like most clinicians, the CDC's guidelines, evidence-based medicine, to say how are we going to make our next steps. So again, just a little bit of a summary of where we are, what we are doing right now. This is a screenshot of our pulse link. This is basically our opiate utilization reduction committee is one that is led by our system office. We have representatives from most of the 92 hospitals, and this WebEx is something that I participate in as a representative from my hospital once a month. This is a time to share information, share initiatives, and to help structure sort of a more cohesive plan for how we tackle this problem. You could imagine that different hospitals from different areas with different resources really have different abilities to impact the opiate problem. So a small community hospital like where I work, which is a safety net hospital, has a large population of patients who have substance use disorder. Many times we are the hospital systems that have the least resources. And trying to coordinate aftercare for these patients with treatment centers that are outside our system and outside the reach of our patients because of their insurance or their ability to follow that without a lead is really a huge barrier. This monthly meeting where we talk about this as a group, again, allows us to share that. It allows the healthcare workers that are working in a system with a lot of resources to share their projects and allows us to kind of strive toward that. And then it allows us to bring everyone back to reality to say that that's a great idea. How do we do that? You know, we can't. I would love to have that resource, but I don't have the staff, the money. The insurance company won't pay for this. So that's the perspective that we bring together as a group. This is the National Quality Forum put together an opiate stewardship playbook, which is, again, a fantastic example of a collaborative project where there is a large outline that is general that can be followed in any health system. General guidelines of administratively how to roll this out to your teams, how to change the thinking of how we treat pain, how do we best do this in a large hospital system. And again, this does cross over where they have a lot of resources or a few resources. You can use this and build your team around this. Our opiate utilization reduction team at Mercy Fitzgerald and Mercy Philadelphia and Nazareth, the health system that I'm working in, we are tackling each one of these guidelines with each time we meet and trying to push some of these ideas forward. So it's a great resource. And it's appreciated that these guidelines come forward from a national respected evidence-based team because it's been vetted already. It's not something that someone's going to question. So these are the sort of collaborations that we appreciate. Just an example of the charter, again, where this is something that we did, and we have this within our health system, again, to just, again, underscore the importance of this and the guide what everyone in our team is doing. So we've shared this with our health team. And this is just a list of some of the specialties that we have on our opiate utilization reduction, our pain management. We realized that even within our small system, we had siloed groups. I was working on opiate utilization reduction, and we kept talking about pain management because that was integral to how we would deal with the opiate problem. And just to find out that someone else had already started a pain management initiative, and so we combined our forces, and now we're a larger group. So again, just an example of how good work happens in silos, and then it just takes a team like this to say, hey, we can work together. And this is an example of our policy. We have an emergency medicine policy. Again, this is all work that we've been doing toward this, where we have opiate prescribing now. That first effective date was in 2015, and that is something we had followed through our professional society within emergency medicine to kind of limit opiate use and misuse. And then that, we have now obviously updated that with some of the new information, and below that is an example of one of the pain contracts we have with some of our patients. Again, trying to prevent this problem from getting any bigger. This is just a screenshot of our PDMP login. Again, the PDMP has been a fantastic success and allows us to again, take a patient as an individual, see what kind of medications they've been getting, and that can put their need for more or continued treatment into perspective. So, and what's happened here through our team has allowed us to do this in a very seamless way with a single sign-on with the badge. And again, that's taken time and energy and money to do that. But creating pathways and creating processes that are simple really is paramount. And again, and I'm speaking from an emergency medicine lens, but I think I'm speaking for any healthcare worker, anyone that works in a hospital, that anything that we are designing here needs to be formulated and designed with as few barriers as possible. Because this is something that we're doing over and over and over and over again during the day. And so, taking 3 minutes to log into a database or putting some regulation into the fabric of healthcare delivery, and then you multiply that by the 50 patients you see that day or the 75 patients you see that day, is hours of time. So again, as we move forward, again, I just want to make sure that perspective is shared and appreciated. And this is some of our tracking. Again, this is something that we're doing for our physicians, where we're giving them back reports to show their prescribing habits. And we're comparing our physicians against your colleagues, against national averages. And again, this is the hope is that any policies that are put forth are not punitive. This is information sharing. There are physicians where their patient population is one that may need controlled substances for hospice care, for palliative care, for failures of other treatment modalities. But again, this type of information allows us to reflect on what we've done, how we practiced for the last however many years, and then to maybe change our perspective as we get new options. And that gets into the part where, so what I just talked about, I think, are the successes of what's happened so far. I think that the healthcare teams appreciate that there's an huge opiate problem. We are working hard, and we're doing that currently to prevent new opiate addictions. And I think the tools that I just outlined are ones that are the huge successes. The treatment. So that takes care of trying to prevent new addictions. And now we move into how do we treat those that are already addicted. A much bigger problem, a much more siloed system. And this is an example of what we do, a warm handoff. In the emergency department, we are trying to take patients who have overdosed or who come in and say they have substance use disorder, and we try to place them into a pathway of care. In the area that I work, this warm handoff involves a team that is not at my hospital, so they are remote. You can imagine that the patients that we see in the emergency department, as much as this seems intuitive to say you just overdosed and almost died, and I can get you to someone that can help you, very few patients take advantage of this resource. We keep looking at this, and we try to tell someone, we try to show them that this is not something you're going to get in trouble. This will be helpful. At least have a conversation, educate yourself. These people, these counselors want to help you. The difficulty is that the time that we're seeing these patients, they're in acute withdrawal. They are suffering, and part of this brain disorder is that it's very hard for them to accept that help at that time. And there's also challenges because these resources are not at every hospital. There are hospitals with resources that have a recovery specialist, and I would say that any legislation that really supports the funding of recovery specialists at each and every emergency department is one that is necessary for anything else that we do to work. Because what happens is, if you're lucky enough to work in a large health system with large behavioral health and addiction medicine, you have someone there to take that patient physically and have that conversation face to face, the success rate will be much higher. This is part of our education packet. Again, this is the good and bad of what we do. There is so much education around this, and almost too much. And part of the challenge of the team that I'm working with now is to really filter through this education, make it palatable, make it understandable, make it readable. We get packets, and I get packets all the time that are pages and pages and pages long, and not all of it pertains to my particular circumstance. So again, part of the work that's being done is to take all this great work and to filter it down into a system that is available to everyone. I have been involved with even some regional summits where I've heard fantastic talks of how resources are there, even in our in our county, in our neighboring counties, and how do I get my patient to that specific person? We have systems in the state that are really set up to make a single call. Our child line for child abuse, we call one number. That number is given to someone who's a specialist. That specialist will then disseminate that information to a local resource who will then call us to make sure that child's safe. We don't have that for opiates right now. So all this information is there, but if we followed a model such as the child line, or for a ward representative, for women who come in for rape, it's one call, and then there's a process that's activated. We don't quite have that for opiates right now, but it would be fantastic to take all this and create that. And this is our quality scoreboard. So this is just, again, we take this seriously in our hospital. So we're going to track this at our quality council, to show that we're actually using different modalities to treat pain. And it's something that, again, will give some feedback to the rest of our team so they can fine tune their approach here. So again, the presentation was really one of showing you what we've done so far, and I think we've done a lot of good work, but it really is a very small portion of what this problem involves. And you'll hear from others today that are working outside my department, ones that I would love to have access to in a very simple way. And again, as I look through this legislature and bills that are being put forth, even the requirement that the payers take away those burdens. I can't underscore enough the complexity of simply trying to get a patient in need to get help that will be accepted, will be funded, and can be done without paperwork and case managers and checking their insurance. We're not there yet, but we hope to be there. And this problem specifically is one where patients don't set up appointments and come in. These patients come in to our department, and we're seeing the ones at the most risk. But that also, they're coming in at times when we have the least resources to give them help. I appreciate your time.
Great, thank you very much, and hopefully we get some questions. If not, I'm sure us around the table there are plenty of questions. Yes? Feel free to step up closer. I think you can all hear us, but I think we're being taped, so.
Hi, I'm Becca Salmon. I'm the Executive Director of the Democratic House Health Committee. We touched a little bit on warm handoff. And we do talk about it a lot. I know every hospital is different. My sister works at a busy urban, she's an emergency room physician as well. She works at a busy urban hospital. Can you talk me through what happens at your hospital with warm handoff?
Sure. So in my county, so it's interesting because in the county I'm in, Delaware County, but we're on the border of Philadelphia County. We get medics from different counties. But specifically in Delaware County, the warm handoff counselors are, their program is supported by the county, but it's executed by the other health system in our county. So not working with healthcare workers that are within our system. if someone comes into the emergency department and they have overdosed, we have a pamphlet, we treat their medical condition, we tell them there is a recovery specialist who is on call 24 hours a day. I would love for you to let us call them, and they'll talk to you on the phone, and we will try to get you some help. If you want to do something tonight, we can do something tonight. If you want to do something tomorrow, we'll do it tomorrow. If you need to be picked up, they'll come and pick you up. You got here. You got here to see me because something bad happened. Let's try not to let that happen again. We'll call up the recovery specialist, and then we'll let the patient speak with them, and then I'll speak with them. And unfortunately, the majority of the times, the patients in that circumstance are in full withdrawal.
Right.
They are not ready to maybe make that step. We cross our fingers when they leave. We give them the pamphlet. We circle the number. We hope that there'll be another outreach. We try to get the recovery specialist to get their contact information. But because they are remote and they're not in there, and because at the time that this is happening, it was usually evening and off hours, and the emergency physician there or even the nurses have a limited amount of time that they can dedicate to that person's problem. And so it is a fantastic idea, and I'm glad we have the program. I wish more people took advantage of it. What I really wish is that I was able to go to my administration and say, I would love to put a recovery specialist on site, because I think that the face-to-face it's important. And if we're taking advantage of the fact that someone's there in the emergency department, that face-to-face makes a huge difference. But it's a resource, and it can be a costly resource. But they are the experts, and again, them more than myself know what that patient may need next.
I know some hospitals are starting as part of their warm handoff. They give the first dose of medication-assisted treatment. What's your opinion on that?
So the buprenorphine, I mean, to get a waiver, we've spoken about this. At my health system, because we do not have a specific handoff. We don't have a dedicated second step. We have not adopted that. To adopt that sort of process, I would need to be able to speak to someone who will take my few-day waiver buprenorphine and then continue it. That's not available to me right now. And so there are health systems that do that have been able to dedicate that through, whether it's through their own system or through grants, but to have let's say for example, a county MAT program that was available to every emergency medicine physician, regardless of insurance, regardless of where they're coming from, I would be able to, and I think most emergency medicine physicians would say, I'm happy to write for 5 days or 7 days of this, but I need to know that this patient is going to the next step. This is not much different than when I have to discharge someone with a heart condition. You don't need to be in the hospital, but you can't go home for 2 weeks and not know what you're doing. I'm a major cardiology appointment. This is no different. But that resource doesn't exist right now. So again, what the ask would be is if we were able to set up some sort of county system or state system that was accessible to everyone, you will get buy-in from doctors in my specialty.
And just one more thing, as policymakers, this is something that I know that you as physicians really don't like when we do. When we write legislation making requirements regarding when you can't prescribe drugs, and kind of put your guidelines into statute. And working on legislation like that, we often try and tread a very fine line between making sure patients can get access to the medication they need and making sure that we're not furthering this problem. Because if you shut off that spigot entirely, you're going to have people that have, stage 4 cancer trying to get pain relief from alternative sources.
We already see it.
And by alternative sources, I mean street drugs. Do you see that?
We do. The unintended consequences of this opiate reduction has been patients that, at least in my clinical opinion, there is a role for limited opiate use. And it isn't a, yes, you need it, no, you don't need it. There are sometimes you need it.
Right.
And so, yes, of course, as a clinician, I do appreciate that there are guidelines. I think the vast majority of physicians will follow those guidelines and do it responsibly. But what I've also seen is a misinterpretation of the guidelines, and for fear of some sort of punitive effect coming down. And what the clearest example would be some of the primary doctors that have just given up opiate prescribing completely because of fear of some sort of punishment or being tagged as someone who's an opiate dealer. So I think that has to be, and you touched on it. And in the emergency department, we've seen more and more of that. So we would see patients who needed breakthrough pain medicines, but now we see patients who say, I don't even know what to do, and we didn't talk about this, but the sort of commitment to pain management centers and supporting real academic pain centers, not the mom and pop shops, but the ones that are really run through larger health systems that have multiple disciplines involved. So, but we are already seeing the unintended consequences.
And with respect to that, I speak from multiple places. I'm not only in a space where I write legislation around it, I also have stage 1 breast cancer. I'm doing fine, everything's great. My boss has pancreatic cancer. And the two of us have seen, in the infusion rooms and when I've been admitted in the hospital, people who have tremendous amounts of pain. And I had one roommate who had stage 4 ovarian cancer. And she was just in tremendous amounts of pain. And to imagine that, to deny a fellow cancer warrior the pain medicine that they needed is just something that's unimaginable.
And the payers contribute to that. The payers contribute to that. And so again, when we speak about something so important, and again, I use something as bad as child abuse. No one ever questions when we call the child line and we try to get resources around. No one would ever question getting everything done. And this problem should be no different. So tremendously frustrating to have patients come and say, well, my prescription wasn't, I got 7 days and I had orthopedic surgery, but they had a complication and they need more, but the orthopedic can't write anymore and the primary care won't write anymore. So yes, the overregulation does affect it, and a lot of times where they end up is in the most expensive area for healthcare, which is so again, with a little bit of forethought, with a little bit of trust of sort of the clinicians. I think there's a role for oversight from peer committees through, we can certainly do that.
Great, thank you so much.
So thank you for that question. And I'm going to try to, as the moderator, to keep us on time. We're going to have time at the end for other questions. And so I'd like to move to the next speaker, who is Mr. David McKeegan. He's the Executive Director of the Delaware and Chester County Medical Societies. And I first met David a couple weeks ago as he was presenting another function, really about the Regional Overdose Prevention Coalition in Southeast PA. David has a long experience in many commitments around health education, suicide prevention, and he speaks from experience in many areas of behavioral health. So without further ado,
thank you, Dr. Yes, I'm very pleased to be here. Always great to work with our local health systems. And we see this as a public health epidemic. There's no doubt about that. I like using the word epidemic. Epidemic is a public health term. It means that we're not winning at it. It means that we are still losing more people than we lost last year. I think the two physicians that preceded me will like my first slide here, because we always will start by reminding everybody in the room that substance abuse is a disease. Substance abuse disorders are a disease. We've become more familiar all the time with the warning signs, the symptoms of these diseases, and the repercussions. There's more talk about opioid addiction and overdose than there has ever been, and that's maybe one of the only good things about where we are now. The other good thing, possibly, is that we're learning about how people get addicted and how we can treat them. Very important. There's a lot of new learning going on. The epidemic is pretty well defined. You don't need me to tell you to what extent. It's got to be 14 people a day probably now in Pennsylvania that we are losing, whether it's street drugs like heroin and fentanyl or prescription drugs like opioids. Most often it's a combination. I think most of you probably know that already. The typical response is where I really want to start my talk. The typical response in a situation like this is that local governments, local hospitals, local health systems, they'll huddle. They'll do a good job of studying it. They'll start their own task force or work group or special attention group. And then they'll work real hard and learn and say what can they do within our system. The problem is sometimes we have all these different silos and we're not speaking to each other. So, as my first slide said, I participate in the Delaware County Heroin Task Force, which is coordinated by our Delaware County District Attorney. I also get to talk with the folks at the Chester County Overdose Task Force, which is also drawn together from folks in law enforcement. But both of these groups include a wide range of stakeholders, people from academics, people from medicine and healthcare, people from pharmacology, people from behavioral healthcare. And our regional approach is to bring people together from the Delaware County, the Chester County, the Bucks County, the Montgomery County, the Philadelphia County, and now even the Camden County and Newcastle County task forces on overdose. And what can we learn together? I should also say that the woman to my right is one of my partners in this, Rosemary Hall, who you'll hear from later. Rosemary and I both serve on the executive committee of this regional overdose prevention coalition. We're very excited. As I said, it is a wide range of different professional people. We try to meet often, but not too often. We don't want to have our programs be a barrier for working together. Typically, Dr. Cassidy and I often say we meet 3 or 4 times a year as a regional group. It began about 2 years ago when we started planning this. Our very first regional meetings were in early 2017. When we first got together, we realized there was value in this. We were offering some proper prescribing programs for physicians. And we did one in Philadelphia and then one in Delaware County 2 days later. And in the day between, we hosted a symposium for people who thought they might want to work together. And lo and behold, we got a great interest and a lot of turnout in that. Our first program was in March of 2017 at the Philadelphia County Medical Society. We had well over 100 physicians who got trained in a program that came to us through the University of Boston. And it's called SCOPE, or Safe Prescribing. The dialogue then was terrific. We brought in some legal people to join us and say, where else can you go? And we had another meeting 3 months later out in Westchester, in Chester County. Each of these meetings had about 100, maybe 90 people, 90 to 100 people. As I said, a good cross-section. We set it up with an interesting keynote address and then breakout sessions, divided up by topics. We had a lot of question and answer earlier about warm handoff. That is certainly one of the most key topics in our regional discussions, the warm handoff. Our next program was held in Delaware County, a place called the Glen Mills Schools. Glen Mills is a world-class facility that treats incarcerated male youth. In Delaware County, they have kids from all over the country that come to Glen Mills. And they have a very, very special medical unit there, too. I can tell you more about that some other time. In October of 2017, at this meeting, we decided that we needed a little bit of structure. So we began talking, we sought representatives from each of the different counties that were part of our team, and we chose some that were willing to work together as a leadership team, and we meet very regularly by phone conference. Our most recent meeting was in February, held at the Bucks County Community College. Another stellar turnout, great breakout sessions. Representatives from 5 or 6 different health systems by this time. We're starting to reach other people. Our Work groups are continuing to do works in between the times of our meetings. And I'll tell you a little bit about those work groups in just a second. Right now, though, we are planning our next meeting for next Friday at the Montgomery County Community College. We have a special focus on the justice system, MATs within the justice system, and a lot of other stuff to continue from the last program. I did want to insert one other point that I neglected earlier, in terms of if there is any good news. If there is good news on the opioid epidemic, in my opinion, I have seen some statistics recently that says Pennsylvania physicians are writing less opioid prescriptions. I'm not going to say how much less. We don't really know that for sure. The PDMP that you mentioned, doctor, is an important tool. We need to make sure that physicians are encouraged to properly use the PDMP. I have a friend that has an alternative to PDMP. It's actually an upgrade. If your PDMP view is that of looking at an Excel spreadsheet, and yes, you can tell whoever else has prescribed and whoever else has filled. This one's like PlayStation. It's animated. It shows up in Google Maps, and it shows you every provider that's been tapped. It also will link with or sync with your EMR and go right through it and identify a printout on everybody that you're going to see tomorrow. It doesn't work so well in ED, I realize, but a pain practice or orthopedic practice probably works out pretty well. As I said, we are planning an open program. This is not necessarily by invitation only. We like to keep it to what we call stakeholders, and you can define for your stakeholder. The ROPC endeavors, though, we wanted to do a regional treatment inventory and really know where we can get these folks some help. My idea, and I was excited to meet the people that develop apps here. Wouldn't it be great if we had a phone app? Here in Delaware County or Chester County, you could go on that and you could see where there are beds available that day. You could see if there's a payer involved and they're going to accept that. That's the kind of immediacy that we think we need and we're willing to work towards getting. Our treatment inventory, it's kind of a need for a real-time inventory at this point. It takes your caseworkers and our certified peer recovery specialists a lot of work to find just the right place for people sometimes. Warm handoff, I mentioned before, it was certainly emphasized. In my opinion, this is probably the most critical aspect of getting people into treatment. They can do this if they're motivated and if the right people are helping. There's no doubt about that. Warm handoff, as you said earlier, may begin in the ED with some medication-assisted treatment at that point, or it may lead right into a detox and then begin afterwards. Great question. That's one that we are certainly discussing and promoting the availabilities of MATs in emergency departments. Safer prescribing, yes, this is kind of at the core of things. The folks I represent, practicing physicians, have been accused of being a big part of the problem. We can acknowledge that and go forward. We will also tell you that there are a lot of other stakeholders who have culpability there. I don't want to get into big pharma and payers and rating people according to pain scales. You may remember a movie a while ago where Gordon Gekko in Wall Street says, "Greed is good." I mean, no disrespect to anybody that's in pain, but in my opinion, sometimes pain is good too. It helps us to know what our body's going through. And if we are conditioned and we are set up so that we should never feel as though we have pain, we're not looking at this in the right way. One time here, Catherine. Payer collaboration. This is one of the other ones that I am most proud of in terms of some of the work that we can do. Some of it due to relationships we have with payers, and some of it with them feeling as though we have our eye on the ball and that we want to make some progress. Bring a group of payers together and who has more data than these folks. And the good news is that they mine their data. They know what they have. Each of these payers that we've met with, whether it was Aetna or IBC in Philadelphia or CMS, they all have their own task forces on opioid overdose and abuse, and we can learn a lot from them. We can also develop positive relationships with those folks and then ask them to work with us in getting rid of some of the barriers to care. We're working on that. Legislative, yes. Maybe 150 bills in any one session that address some part of the overdose epidemic. Or said it again, epidemic. We need to make sure that we're on the same page as providers and systems, and that we're working together. There are some things pending that I'd like to speak to people after the meeting about that I don't think will be helpful, especially as they pertain to my goal to get more providers out there interested in medication-assisted treatment. I think that's one of our big goals. We need to have more access for the public, so we need more providers that are credentialed to do so. Communications, certainly a biggie also. If there's a bad batch on the street in Darby, I want communications with people in West Philadelphia and Center City so that we know. We need to continue to focus on communications behind the scenes, and so we work closely with the law enforcement folks on that. In conclusion, I'd like to thank the people that I stole these slides from. Dr. Cassidy from the Chester County Health Department. Renee Cassidy is remarkable. She works part-time for the Chester County Health Department, serves as the chair of our regional committee, and on her 2 days off, she volunteers at Community Volunteers in Medicine, our public health clinic in Westchester. Aviva Forber has been partner most of the time without presenting and talking about this epidemic, and he is a board-certified family doctor, who's also boarded in addictions and now has a private practice of addiction medicine in Ardmore. Thank you very much for an opportunity to be here.
All right, thank you very much. So we're going to, in order to keep us on time, we're going to go right to our next speaker and maybe lump the two presenters in the same question bucket, so to speak. And our next speaker is Rosemary Hall. She's the Senior Director of Policy at Maternity Care Coalition. She's a registered pharmacist with a master's degree in public health and has a long and important career in helping inform communities and legislators in improving safe medication practices and health policies in child care and public health systems. And she's also an executive member of the Southeast Regional Overdose Prevention Coalition.
Thank you. And I just want to thank David particularly. He's really been a leader in getting this regional group together, and that leadership makes a difference oftentimes. So, here we go. I represent Maternity Care Coalition. It was born in 1980, actually, because of the infant mortality rates in Philadelphia were higher than most African countries. And we were designated from City Council, and along with the collaboration of many people in the area that wanted to do something about this. We have been around a long time. We've been through the crack epidemic. We've been through, all kinds of other things. But the one thing we know is that if you strengthen families, you can help them. And so that's kind of why we got involved with the RPC. We're kind of like a case study today, so I'm going to go through and do a little bit more in depth. The one thing I just want to note is the Maternity Care Coalition is in the 4 counties in the Southeast region. So we're in Philadelphia, Bucks, Montgomery, and Delaware County, and we service over 5,000 families a year. We are unique in that we do everything from early Head Start to our Safe Start program with the University of Pennsylvania. We are also partnering with the Centers of Excellence at Temple and at Penn. And we also have a special program with the Medicaid managed care organizations where if a baby is diagnosed with neonatal abstinence syndrome, before they leave the hospital, we are assigned that case and we follow the baby. No matter where the mom goes, mom might go into treatment, but we follow the baby for the first year of life. And why do we do that? Because this baby Summer Chambers, died December 19th, 2016, because both parents overdosed and the baby starved to death in 10 days. And so what I usually tell people is that babies usually don't die of neonatal abstinence syndrome. They die from abuse and neglect the first year of life. So this is, most of us have seen this who have been working in this, but I really wanted to put up this, the drug-related overdose deaths, because in public health, which is my other hat, it's really important to have data, have information, have mapping, and this really highlights what we're seeing in our region, particularly around Philadelphia, Delaware County, and Montgomery County, that have really seen increasing rates of death. And this is a quick snapshot for the drug-exposed babies. So we're talking about overdose deaths. Well, the neonatal abstinence syndrome, also has a similar line, and you can relate it to the number of deaths in the area. And as you can see here, there's really specific pockets. And what we have found in Maternity Care Coalition is we try to target the zip codes, because that's really important. If you target the zip codes where the highest number of deaths and the highest number of babies being with neonatal abstinence syndrome, we actually have a car called the Momobile that goes into the neighborhoods. They recognize our car. People come out and start talking to us. We give them diapers and formula, and they say, hey, my neighbor may need help, or I need help. And so it's another way that we get into the communities. So, of course, this is a two-generational impact. And one of the most important things, as we see, so nationally, there was 437,500 children placed in foster care. 25% of them were for parental drug use. In Pennsylvania, 16,000 children in foster care, with 55% of them were much higher than the national average, taken because of parental drug use. And the majority of family placements are with grandparents. So now it's becoming a three-generation impact. So one of the things that we're working on with the RPC is doing a perinatal review of what this impact is for our region. And what we're looking at is child fatalities. So in 2012, there was 105 fatalities in Pennsylvania. In 2017, that number rose to 243 child fatalities or near fatalities, and 81% of them were children under the age of 3. In 2017, in the Southeast region, we had 30 child fatalities. On this side of the screen, and I know it's really hard to see for the people in the back, so what I really want to take home, and you can easily see this part of it, is you can see the increasing surge of drug-exposed babies. Many of the babies are not being just opioid exposure, as many of the physicians can attest to. What we're seeing is often the mom is using multiple agents. So we have moms who are on benzodiazepines and opioids. And then the increasing risk now with carfentanil, particularly around the Philadelphia area, has really been presenting a challenge because, and I meant to tell you this part, I was talking to a police officer who informed me, oh yeah, the new trick is they're adding these new agents into the carfentanil that are not considered illegal, so that if somebody overdoses, they may not be charged with a felony. It's a weird thing in the law. So there's increasing things that around protecting the children, of course. There is a federal law that's called the Plan of Safe Care under Captain Care. And in the Plan of Safe Care, which Pennsylvania has not fully adopted yet, they're working on it, it's really supposed to lay out who's actually responsible for this child or this baby with a parent that suffered from opioid addiction or from substance use disorder. And so the critical piece is, and I like to think of it as more of a clock. So if you look at it as the child in the center of the clock, you need to find child care. If the family's connected to the correctional facilities. We service women in the Riverside Correctional Facility in Philadelphia. We service about 50 pregnant women in the correctional facility every year. Many of them come from a history of substance use disorder. So really making that critical link. As David said, we're going to be doing at our next Regional Opioid Task Force meeting, looking at evidence-based home visiting. In Pennsylvania, 79% of the children under the age of 0 to 5 who are at risk for or known to the child welfare system do not receive any kind of link to the child welfare system. Drug and alcohol treatment is critical. So we are not a drug and alcohol treatment program, but we work closely with them and we connect mom to the resources she needs to be successful in that treatment. And of course, behavioral health. Lots of things that mom has to do. And then think of the brain changes in a woman that's fighting substance use disorder. Think of the economic barriers. Think of the things that she's battling every day with housing and transportation. And what do you do with your kids when you go for a medication-assisted treatment? And you have to report every day. And there's lots of barriers. So figuring out how do we break down those barriers. So So in closing, I just want to really kind of give this little example of how the RPC kind of is helping us build the process of breaking down these silos. So we started with this acknowledgement of the NAS and the Plan of Safe Care concerns through our perinatal subcommittee. And now we're working with the legislative committee to say, is there a way that we can look at the current bills and then also work with the legislators in proposing bills that may be helpful. And then we're also working on a white paper and further communication. I really want to highlight that because it's not just a bunch of us getting around giving presentations, it's really us taking action steps that make a difference in these families' lives. And really quickly, because I was asked to tell our pieces of this, yesterday House Bill 129 was passed, and unfortunately, it's one of those unintended consequences bill, but it really hurts women with domestic violence and sexual assault. It hurts drug treatment programs. It was pegged as the drug kingpin bill, but it really had the opposite effect because of the way Pennsylvania law is stated. So most of the women that would be affected of this, a lot of them suffer from substance use disorder, and it penalizes them for the rest of their life if she tests positive twice, and even if she participates in a drug treatment program and has been convicted of a felony use. And in Pennsylvania, that can be for a very small quantity. And again, many of these women have a history of abuse themselves, and this is, penalizing somebody who's in the middle of trying to get substance use disorder. And TANF and WIC really penalizes the children. So we're hoping that the Senate sees the light of that and doesn't continue to pass this bill. And then one other thing is that we are advocating for is evidence-based home visiting. Right now, within the Pennsylvania budget, there's a line item for evidence-based home visiting, like Early Head Start Nurse Family Partnership, with 800 seats designated for families suffering from opioid addiction. So we're in support of that. And that's it.
Great, thank you. We have time for questions. Yes? Yeah, it'd be great. I'll go front. Thank you.
I'll be brief, I promise. I see we're running a little bit behind already, but real quickly, just as background, my boss was sponsor of the bill that became law enhancing the continuing medical education requirements for docs in terms of pain management and addiction. He did have the minor prescribing legislation limiting it to 7 days, which was signed into law. We have the 7-day bill for everyone across the board with exceptions, I want to add. And then we also have prescribing guidelines bills making those mandatory for doctors. Addiction and heroin, opioid overdose and misuse, abuse and misuse is nothing new for us, but I guess my questions are this, and I apologize if you did say this before. How well do you guys work with the centers of excellence that are in your region? Do you work with the centers of excellence?
Yes. So we do work with the centers of excellence. Many of them are part of the regional group. My particular agency works with 2 of them, and then we also include them often in our breakout sessions, and they have really been critical in helping us bridge the many questions that we're having.
Yeah, I think their knowledge and their experience flows over beyond their own center and is picked up, as you're saying, at each of the entities in our counties. Great question.
Another thing, finally, if it's okay, medical marijuana. A lot of studies are coming out now saying that, I guess I should say medical cannabis, I won't say medical marijuana, but the effectiveness in treating opioid disorders. What's your thoughts on that?
We have a lot of panel. We want to open it up to the general panel.
Yeah, I was going to say, the regional opioid, the regional overdose prevention coalition doesn't have a position on this yet, and we haven't even released them.
We have done some training and provided the certification that physicians need in order for them to recommend medical marijuana. And you can say that because that's what the state calls it. Only in Pennsylvania, though. Dr. Levine, for one, will say that she believes it is a deterrent to some. I believe that that could be for some. I don't know, though, that it's going to substitute for what would determine a serious opioid addiction. It's just not going to work quite that way. I think what we do see is medical or illegal or street marijuana very present in most overdose cases. We refer to it as polydrug involvement, and there's just numbers of substances that people are using. I'm a little afraid of the tendency for it to be abused, but at the same time, I'm delighted for people that suffer from chronic pain, they may have something else. Just when we thought we had this opioid epidemic understood, you all gave us medical marijuana.
Exactly. I think
I'm a family practice physician and deal with this patient the patient population pretty extensively. There is no good data on medical marijuana being effective. There's data, but there's not good data because the FDA hasn't been able to reschedule this drug. The clinical trials and the good studies that it would take to really show the efficacy just can't happen until the FDA would reschedule that drug. So we just don't know. There are drugs that are effective, and there are drugs that are effective for pain. What you have to do as a primary care physician to get topical analgesics prescribed to your patient or alternative pain therapies like biofeedback, physical therapy, a multidisciplinary pain program are Herculean to get for patients. And it's just, why don't we work with what we know works and has been FDA approved rather than go to something that we just don't know. We just don't know.
I would support that as well. And I think although the health system doesn't have a specific position on it, not well studied, we see a tremendous increase in something, cannabis hyperemesis syndrome in the emergency department. We see patients who come in with cyclic vomiting, and this is really a direct result of kind of attempts to self-medicate for whichever disorder they have. So wholeheartedly agree that much more study needs to be done before this will be endorsed by the clinical teams.
I am just happy to hear everyone in agreement that it is a disease, opioid and heroin addiction. I think we need to do a little bit more in treating it like a disease, like diabetes, and kind of stigma is a whole other issue that I'm sure we could spend a whole day talking about, but thank you for being here. Appreciate it.
Thank you, that's a great question. So in order to keep on time, we're just going to keep moving, and again, we have some time, hopefully again, for general questions for the entire panel. So it's my honor to introduce our next two speakers, Dr. Sister Donna Wando, who is the Vice President of Mission Integration at Mercy Fitzgerald and Mercy Philadelphia Hospitals. She comes to us with over 34 years of time spent for healthcare in the Mercy Health System, and 15 of those at Mercy Fitzgerald. She's also very much involved, obviously, in the community over the years, and been integral in doing the last 3 community health needs assessments at Mercy Fitzgerald. I'll kind of plug, I'll put a little of her introduction, put a plug that as a hospital association, we do look at the community health assessments. There's been very few organizations that have seen opioid use disorder as one of their top 3. They're all starting the next round. I've got good money that will change very quickly. There are only a handful of organizations that put opioid use or substance abuse as a community health need. So that's great work. Also joining her is Sister Mary Elizabeth Burke. She's part of the parish nurse program. She's got over 55 years of healthcare experience across the spectrum. But more importantly, the past 15 years has been parish nurse in the Delaware County. So we have folks who are very much in tune with what's happening in our communities. Thank you.
Well, thank you very much. We're very grateful for the opportunity to present this side of the addiction crisis and look at it from an education and prevention perspective. That community needs assessment, the broad brush, broad look by a health system that filters down into a hospital with its community partners. In this case, being Marcy Fitzgerald Hospital, along with our partner, St. Eugene's Parish in Primos. We sit in the middle of this crisis, and we'd just like to tell you our journey of the last year, and certainly ask for any help that you can give us going forward in terms of prevention and education, because we know that is so key, especially with our young people. So then I hand this off to Sister Mary Elizabeth. I'm going to kind of tag team on this.
Thank you, Donna. Thank you, everyone. Why this partnership and commitment was made, we based, as Sister Donna said, we based this on a community needs assessment in 2016 in Mercy, and it was indeed identified as the highest need within the community. And although I'm in Primos and Clifton Heights are like right next door to each other, it's really fun to go around and find out all the zip codes. Because I've only been there 2 years. I was in Darby for 15. So what is interesting is Sister Donna and I went to a program that was put on by the politicians and the police within the Clifton Heights area, and we found out that we had the highest population. Clifton Heights has the highest population of opiate addictions within the whole state of Pennsylvania. And that kind of blows your mind, and especially when you look up and you see a vast number of young people. So from that experience, we decided we needed to do something within the community. So we went after this program called Lessons in Mercy. And it was given by a professor in psychology who has a daughter that is in rehabilitation. And the mom has spent a lot of time around this whole disease, and she emphasizes the whole fact of the disease. Also, it was the first time that it was ever given from a religious standpoint. The program was called Lessons in Mercy, and it talked about behavioral, psychosocial, spiritual needs of the person. So it was a 4-week series during the summer, and each of the 4 weeks we had at least 75 people that attended, which is kind of an interesting number in a small community for a program in the summertime. However, from that came the need for a support group. People asked us if we could have a support group. So Sister Donna and I set up a support group for anybody interested. But we also heard from these people, so many of them had been touched by this disease through their children or their grandchildren, nieces and nephews. There's not, as someone said earlier, there's not a family that hasn't been affected by this in some way. So we decided we would do a pilot program at St. Eugene's Parish. So we went to the pastor and went to the principal, got the okay to come in with the 8th grade. And we chose the 8th grade for 2 reasons. Number one, they were the 8th grade. And number 2, it's a small school. There's 25 children in the class, and they'll be going into high school in the future, very soon future. And we have had, within this program, we brought in speakers. We talked about bullying, we talked about social media, ideation of suicide to the groups each week. We had a 6-month program with them, one day a month for an hour. And for 3 of the programs, we invited people, young people who had been addicted and were in recovery. One of whom was a young woman who was a graduate of St. Eugene's, who told the group that 25% of her class is in recovery, which is a real mind blower to everybody sitting around there. However, what each one of them talked about was how difficult it was to go from a small school into a large high school and be lost. And that's when their problems of loneliness and feeling not wanted, and that's where they started to experience the bullying and things like that. That's really was the prime motivation for going and using something. And oftentimes it was alcohol. It began with alcohol because it was close by, and then also friends that would say, you know, take some of this, it won't hurt you. So from that program, we called the program Prevent, and we had it for 6 months, and we hope to be able to do it again if we have enough money. And think the 8th grade class really articulated the importance of it. And in addition to us bringing this to them, we had, before we started the program, we had their parents come for a night of, we invited them to dinner and to talk about what we were going to be doing, and then to get their approval. And subsequent to that, we would send information home after every meeting for talking points with their parents, and then at the very end, the outcome and how they felt it went.
She made my job easy. Only one more slide. So, as we developed this program, as Sister said, we included those topics, those subjects that we thought would affect a child in a negative way, would isolate them or make them turn to a substance. And so we also included it within that program. We're very much aware of the work of the Delaware County Narcotics Task Force and the NO program that has been developed to do education in schools. So part of this program was to bring NO in, and at the very end of the program, to have them do their very stark, eye-opening education that kind of shocks the kids into this is what happens if you use drugs. And these are normal, ordinary students like yourself, maybe even your age, who took that step, used a drug, and it was fatal for them. And so we did use that. We want to continue to do that. And I guess we emphasized, I was happy to hear you talk about stigma, certainly through the program in the summer and with the kids. We emphasized that this was something that touches everybody. There should be no stigma attached to it. We certainly heard from the mainly grandparents, aunts and uncles and parents struggling with this. The horrible nightmare that drug abuse is and drug addiction is for them. They wonder, as they say goodbye to their child every day, will they be seeing them again? Because they know that they can fall into this demon, this trap so easily. And so we emphasize no stigma. This affects us all. This is a disease, and there should be no stigma. We should not be ostracizing these people or making them feel like they're facing this alone. How do we reach out and include everybody? And that was the reason for the first part of the program, Lessons in Mercy, was a safe environment where they felt supported. And then with the kids, not to start. And if they see their friends, to please say something, see something, say something. So the program is still in development. I guess one of the things that we learned is that when we had that first meeting with the parents, a number of them did not think their kids were ready for this in 8th grade. They were like, I don't think my son or my daughter's going to know about this. They don't know any of this. And I can guarantee you, after the first session, we knew we were in the right place with the right age of children, and maybe even too late. Maybe we needed to go younger. In the middle of the session, the principal brought us an email, and the email had been sent the night before by one of the kids sitting in front of us, and it was an unbelievable email about drug and alcohol use and sexting and pornography, and we were like, whoa, we're in the right place. It was a sobering reality for us that this is what our kids are facing. And then I guess the other thing is that we tried to put it in a celebratory setting for them and a safe setting. So we started with the party, we ended with the party. We always brought food because we know the kids love food. But we found it to be an effective way to reach them. And they told us that as it was a pilot, our hope is to continue. Our hope is to expand in Delaware County, to maybe get on that task force and become partners with that task force. And how can we continue this education there and in West Philadelphia? And so we ask for support with especially those two bills that Jane referred to House Bill 1984, which is about drug education for kids from 6th to 12th grade, and also that Senate Bill 1013, which is again about education against abuse. So our rallying cry is that we want to get the kids at a young age, and it is about education and prevention. We would be happy if there were any questions.
Yes, questions? Great, thank you very much.
I applaud you and welcome you to our regional coalition anytime you can make it, every time you can.
Thank you.
Great, thank you very much for a great presentation. This is great hope for the next generation. Next conversation, I think we've already sort of touched on this a little bit around medication-assisted treatment, and we have two speakers for that. First, we have Dr. Todd Warber, who's the Chief Medical Officer for the Pittsburgh Mercy Health System. He comes to us with many years of experience. He received his medical and public health degree from the University of Pittsburgh's School of Medicine. He actually served as the medical director for FQHC, that's a federally qualified health center, which in many communities really is the only access to care for underserved and uninsured individuals in our country. He did that for approximately 16 years before starting to work with the Certified Community Behavioral Health Clinic, which he does now. And joining him is Christy Seemiller, who's a substance use disorder care manager, and she comes up to us with many years of experience providing substance use counseling and care management to individuals in the Pittsburgh inner city region. So, without further ado, thank you.
Okay, so I'm a family practice physician. I've been doing this for almost 25 years, and I mostly in clinical. In the past few years, I've taken on some administrative roles at Pittsburgh Mercy. But what we do at Pittsburgh Mercy is that we enter into the lives of very chaotic lives of people that we take care of. So we do primary care and we do mental health care at Pittsburgh Mercy. So we're on the other side of the state. In a population that we call an SMI population, so those are people with serious and persistent mental illness, schizophrenia, severe anxiety disorder, bipolar disorder, severe depression, the type of things that people become hospitalized from. And this patient population that we deal with has a larger burden of substance abuse than the general population. A bipolar patient might have 3 times the burden or risk for substance abuse than the general population. So we see a lot of people that are addicted. They also rock really a large degree of biological complexity. So they have a lot of medical problems as well. And in case you didn't know, if you have a diagnosis of serious mental illness, your likelihood of dying is 25 years younger than the average American. Just having that diagnosis makes you likely to die at the age in your early 50s. So a large degree of biological complexity, a large degree of psychological complexity, and of course with that is the burden of social complexity, homelessness, substance use, lack of social supports, lack of work, criminal involvement, and the like. And then what really gets our attention, in addition to just the human suffering that's going on with this patient population, is the fact that they are the 5% that make up 40 to 50% of healthcare costs in this country. So they're very expensive, very complex patients that use a lot of resources. We are a bit of a unicorn practice, our primary care practice. It's somewhat unusual in the SMI population. In a normal family practice, we try to say that we're a medical home for patients. We have comprehensive care for patients, that it's patient-centered. We coordinate their care. We make it accessible, we make it quality. In addition, our family practice integrates fully with the behavioral health system. And I'll show you another slide that shows all the different services that we're able to integrate and offer. But we're fortunate enough to have more time with our patients, and we can see them more frequently because they need it. We also have had specialized training as primary care physicians to be able to work in a behavioral health care environment. And we have proactive planned communication with the other teams at Pittsburgh Mercy. We started doing this in 2012 after the system did a big study to learn that over half of the patients that were receiving mental health services weren't getting any basic primary care services. And there's a lot of reasons why, but the history of mental illness in the United States has led us to a different kind of epidemic. And we're here to talk about the opiate epidemic because, and that is what's killing a lot of my patients, a lot of our patients at Pittsburgh Mercy. But there are various models that they use in behavioral health that we've had to learn about. One of them is a model called ACT. It's assertive community treatment, and that's where you have a low provider to patient ratio. So if a normal family practice doctor has 2,000 patients that they care for, in this kind of setting, I might have 800 patients that I care for, maybe half or less than half that a normal family practice doctor would have. We meet on a regular team basis, so I'm meeting with a psychiatrist, a care manager, a service coordinator on a regular basis to talk about the subset of our population that are the most at risk for overdose, for death, for hospitalization, for ER utilization. These are all the services. It's a big slide. It's got small print. You guys are way in the back of the room. But the top is where we don't want our patients to be, and that's in jail and in the hospital. It's very expensive to be in jail and in the hospital, and we would like to get them home and out into the community. And every one of those little pills up there is a different service that we offer at Pittsburgh Mercy, from housing to primary care to behavioral health to a crisis center to
intellectual disabilities, residential.
All kinds of different services to try and get patients from the top of that slide to the bottom of the slide. We have a team. This is our team. We're dealing with patients that are being seen by our team, which consists of our primary care physician, again, a psychiatrist, a care manager. We use peers. There are people with mental illness and substance use disorder that are in recovery, and they're able to come alongside other people and help them. Medical assistance, service coordination. Again, we've kind of beat this into the ground. It's a disease. It's a brain disease. We know that it's 50% genetic. We know that it's influenced greatly by comorbid conditions like bipolar, like schizophrenia. We know that the treatment of this, there's no one size fits all. It's not like strep throat where I can prescribe penicillin and 90% of the time it's going to get it. We need to have different treatment options for patients. And the prognosis is greatly dependent upon premorbid conditions. So just two very quick examples. If I had a friend who was a doctor, he fell into addiction, so it doesn't spare anybody. He fell into a serious addiction problem. He went to get help. If you're a physician, if you're a nurse, if you're an airline pilot, if you're a pharmacist, there are special programs that you can enter into for your addiction, your opiate addiction, your alcoholism. They will put you in for several weeks into a structured behavioral program. They will detox you. And then you spend like the next 5 years of your life being carefully monitored. But with that, you can get your licensure back to be an airline pilot, to be a doctor, to be a nurse. Your premorbid status was before you got into addiction, you were doing really well, you fell down, they can get you back up again. It's very expensive, it takes a long time, and you have to be highly motivated. But 90% of those people in 5 years are still clean and sober. That's amazing in substance use disorder. If we can get 1 out of 3 people, I had a nurse. She's a nurse now. She was a Mercy nurse, came to us as a volunteer for a year, 4 years ago. She was on one of our teams, dealing with people that have serious mental illness, serious homelessness, serious addiction. She came in to visit yesterday. We went through a list of 10 people that she spent a ton of time with out in the community. What happened to Mr. Clark? How's Mr. Clark doing? Mr. Clark's not around anymore. He died last year. He got sick. He overdosed. What happened to John? What happened to Bill? All of these things. If they didn't die directly from an overdose, it was in there. It was part of it, or they wouldn't have been on the team. So out of the 10 people that she mentioned, 6 of them were gone. They were gone. They had very poor premorbid status, and we were doing full court press wraparound services, and they still didn't make it. The prognosis is really not good. If we can get 1 out of 3 people sustain recovery in 5 years, that's huge. And that gets us to medication-assisted treatment. We're in the middle of an epidemic. We got to do what we got to do to treat this disease. Buprenorphine works. It works. It doesn't work all the time, and yes, it gets diverted, and yes, there's a lot of problems with it, but it works well in the patients that it works with. And I would say anecdotally, in my practice, 1 out of 3 patients it works really well for. So when we see a patient and we identify them with an opiate use problem, we can enter them into this unicorn medical practice where a primary care physician can do an evaluation, get the blood work, get the testing. We can have a care manager be able to walk them through our very complex medical system to get the buprenorphine covered, get them into the clinic, get them started on it. They can see a psychiatrist. We can get them into mental health treatment to do some behavioral restructuring. But even then, multiple strikes before we get a successful story with patients. I don't know if you want to talk about how we decide who's a candidate, who's a person that we want to enter into the program.
So all of our patients are coming from our primary care practice. So the one thing that sometimes is frustrating to people seeking out help is that we are taking a whole health approach. So we're treating them mentally, physically, and spiritually as a whole. So we're not just throwing medication at it and fixing the problem. There's a whole process to get into it. So you need to be our PCP patient. We're doing the blood work, we're doing the drug screen, we're making sure that you're healthy enough to receive this treatment, or is there a better option for you? The great thing about our program is that everybody's accepted. We have the capacity, because they are our PCP patients, that no one is ever turned away. Do we turn them away from the buprenorphine or from the Vivitrol? Sure, but that's because there's a better option. We still stay connected with those patients. We have other services that we can refer them to, and we utilize the warm handoff procedure across our agency. We sort of never have a handoff because we're constantly in communication and constantly meeting and bringing these patients in that have failed out of other medication-assisted treatment clinics because of their significant mental illness, because of their continued, pre-morbid status, that they were already so far underserved that getting them to a point where they're receiving the services necessary is sort of our first barrier. So bringing them in as a PCP patient is where we start at.
Just some preliminary data. Most of our patients are younger. They're in the age between 30 and 50. Predominantly male than female. Again, high school degrees. We're tracking their mental health diagnosis. You can see the big piece of the pie up there is bipolar disorder. Most of them would say their opiate use began as prescription pills, and that their drug of choice, in addition to an opiate, would be alcohol and cocaine. So anecdotally, we see people, they're coming in and their urine drug screens are dirty for multiple substances. The thing that's killing them is the opiates. The opiates is what's killing them. The carfentanil, the fentanyl, they're overdosing and dying from those. So it used to be if I saw marijuana on a urine drug screen, I was like, I don't like it. I'm like, marijuana, And if I see cocaine now, I'm like, okay, well, that's not going to kill them. Benzodiazepines, well, they take it with the opiates, that's going to kill them. Can't have that, but you just get a different mindset than you used to have 5 years ago. And I've been doing this for a long time, and there's just a different mindset. The PDMP is a great thing to get people from not getting back into the epidemic, because most of them are getting hooked on prescription pain pills. But what we've seen in other states when they implemented the PDMP is they get off the doctor shuts off the pipeline, and then they go to street heroin, and then we see the deaths go up. So we have to have something to be able to get people that's not going to kill them. People don't die from overdosing from buprenorphine. You can't. It's the pharmacology of it is you really can't overdose from it. It's the carfentanil, it's the fentanyl, it's the heroin. This is just a feel-good case. I don't know if you want to talk about Cassie, but this is a patient that our team really tried and is a little bit better with feel-good.
So Cassie was one that we really had a hard time, agreeing as a team. So part of our model is that we rotate psychiatrists, which can be great if everybody is on the same page. And generally we are, and generally they have the same treatment modality, which is, the team works really well together. Cassie presented us with some unique situations because Cassie tested positive for cocaine 7 times. So any other treatment clinic, Cassie would have been kicked out 3 separate times from those 7 positives. Cassie had problems with housing. She was at risk of losing her housing because she had gotten drug charges for possession, and a neighbor had turned her into the Section 8 office, and Section 8 filed an eviction notice because she had legal charges pending. So her children were removed in that process through CYF. They were placed with a paternal grandfather. She had limited access to her teenage daughters, one of which was in and out of the mental health hospitals with a recent diagnosis of schizophrenia. Cassie had previously received mobile mental health therapy, which means she was getting a therapist coming into her home. She was had social anxiety, wasn't leaving her house. So all of these things, I remember Dr. Warburger meeting with her after the 3rd or the 4th positive test, and you felt like there was nothing you could say to her because you got it, you understood. There were so many of these things that were happening for her that just weren't progressing. And you couldn't just pick one, because if you ask somebody to choose between their addiction, their housing, and their children, how on earth could that choice be made? So it was really, we had to wrap all of the services around Cassie. And 6 months later, she has been clean for over 90 days. Her housing status is no longer in question. Section 8 dropped the charges. Her children have been reunited, and she is engaging in long-term therapy. So the model is working. It's getting there. The barrier that we have is, can I do this for every patient? You know, there was so much time and effort spent into her that I'm lucky that I have those resources generally, because I can just email her therapist. I don't have to wait for a return call and a release of information. We're all together, we're all a team, and we can do all of that as one. With that not being the case for everyone, there's only one of me. So right now we're up to 38 active patients. That doesn't include the 96 referrals I've had, and we've only been open since September. So 96 people have been screened, assessed, and either admitted or found a different pathway. So doing all of those things, that we have here with Cassie to get her through, that's where we struggle, that reimbursable concept of the heavy workload piece of it. The support staff are often what is doing the bulk of it, and it's not moving forward in the reimbursable piece. The payers aren't acknowledging the heavy workload of the case management pieces.
Which is still way cheaper than an inpatient structuring 30-day program for a patient. So, what we need is help with, people can't lose their medical assistance. If they lose their medical assistance and they fall into addiction, it is in some ways a death sentence. You can't get them the medication and the treatment that they need. We need, for innovative practices that are able to meet this 5% population, ways to be able to pay for care management services aren't available at this point. And again, this is cost-effective medicine. It's way more expensive to have them show up in your emergency room. And even if you saw them once, you're going to see them again if you can't plug them in and have them land in a robust practice that has the time and the resources to be able to make it stick. Even then, it's only going to stick probably 40 to 50% of the time. That's better than zero, because this is a bad disease. It's a really, really hard disease to treat. It takes sustained effort. It takes a sustained effort, and you have to have a lot of different tools in your toolbox to be able to treat this.
Questions from our audience?
Any general questions?
Yeah, are there any general questions? Maybe as you heard the individual presentations, the panel will be happy to answer any other general questions on this very important topic. The ice cream is selling in, I think.
I think the one piece too, Dr. Warburger sort of touched on it briefly, but one of the most recent changes, the governor recently has said that anybody under Medicaid no longer needs prior authorization for Suboxone and Vivitrol. which has been phenomenal in accessing the care. When we started, I was telling patients 2 to 3 weeks to get them established on the medication, because by the time we got the lab results back, got the prior authorization, dealt with any of those hurdles, and then actually got them into an appointment, it was really a minimum of 2 weeks. We've cut that down to less than 7 days without the prior authorization. So part of this is the treatment of the disease is expanding those options, that, you know, to be able to do things and pre-authorize them, that's oftentimes a big barrier. And when we can prescribe somebody insulin for diabetes with just a swipe of a pen, but we have to take a 72-hour window to get an injection approved that, you know, could potentially save their life while they're in the ERs and they are sober and, you know, feeling like they need the help now. To start that, and like you said, you have to have somebody to hand that off to. There's so many times where people come in and they say, oh, well, I was started on buprenorphine and I ran out, and so now I'm buying it on the streets, or now I'm doing this. And all of this outreach, pulling it in, there has to be ways to access all of these options, not just a couple.
I have a question. Do you guys do Narcan training for the families?
We do.
As part of your
We
training
do.
program?
We actually ask every week when they come in, they have a survey that they fill out, and one of the questions is, do you have a supply of Narcan? And if they don't, I make sure they get a refill before they leave. We actually keep a supply in our office, and they'll leave with it in hand, and then we replace it later.
So I have a question. So as I travel across the state, you do run into obviously treatment programs who are very adept at a full-fledged program with MAT, and they've got trained psychiatrists. And then we look at the number of addicted individuals in Pennsylvania, right? And that number of treatment providers does not match up. Even the geographic distribution, obviously in the urban areas, there's probably okay numbers, but as you go out in the rural areas, it's maybe 0 for 50, 100 miles. And so the conversation goes around, as a pediatrician, primary care provider, what is the role of primary care, representing the primary care world at some level here. What are your thoughts about barriers or issues with primary care physicians, not opening treatment centers, but actually sort of starting down the path of, as part of the disease, if their interest is in picking up a few of their patients who have this problem and treating the disease with MAT? How do you see the structure set up, and what are the barriers you think that could help make this an easier transition?
I think when buprenorphine came out, it was, I mean, the history of methadone, and methadone being used as a full-on, it turns on the opiate receptor, methadone, right? So it's another opiate, and it satisfies the craving of the addiction. When buprenorphine came out, it was really created to be used as for primary care doctors. It's pretty safe. It works really well. You only have to dose it once a day now. There is actually an injection that somebody can get a dosage of it once a month, so they don't have to be in withdrawal all the time. Being in withdrawal and full dopamine withdrawal is a horrible feeling. So the barriers, I think, are educational barriers. When the drug came out, it was seen as a cash cow for a lot of primary care physicians and providers that they could. The way it's being prescribed right now is not the way I prescribe insulin or high blood pressure medications or any of the other medications that I prescribe. Everybody gets seen in a clinic. You go to your methadone clinic, you go to your Suboxone clinic, and it's an afternoon, and patients just get run through and they get their fill of their medication, and then they go to the behavioral health component. It's not integrated into their practices, and physicians make money off of it. It doesn't need to be that way. I think with proper education, it can be like you have a disease, like you have diabetes, like you have high blood pressure, like you have substance use disorder, and our psychiatrists are trying to integrate that into their practices, just like I'm treating your depression, I'm treating your opiate addiction, I'm treating your schizophrenia, and not just isolating you in the stigma again into this clinic that you kind of come into and you got to show up in. There's a lot of safety around this medication that I think But I think it's the stigma. I think a lot of primary care doctors see it as, I don't want to be one of those doctors. Those doctors are just they're taking cash, they're taking advantage of a patient's addiction, and there's just that stigma of, I don't want to be one of those doctors that writes that up. And there's a fear of that, and then there's a fear these patients will scare off all of my other patients. So there's all this stigma around addiction, around these patients that are coming into your waiting room. You know, a lot of my patients, like, I like hanging out in your waiting room. It's very entertaining. It's, yeah.
It's hard to, when you take away the ability for prescribers to continue writing a medication, then you're increasing the barriers for patients to have access to services. Last night in clinic, one of the psychiatrists was talking to us about Senate Bill 1054 that is being circulated, talking about certifying physicians with ASAM to make sure that they are certified in the addiction medicine before they can prescribe Suboxone. So that's on top of the data waiver that there is currently to get to prescribe Suboxone. Right now in the state of Pennsylvania, there's 42 of those doctors. So you would take away all of these options in primary care. You know, our clinic is very tightly run. They get a drug screen every time. They are filling out questionnaires. We're assessing their withdrawal symptoms. We're asking them if they need housing help. Do they have food at home? All of these things are integrated. That's the ability that we have with spending more time, that ACT model that he had talked about, that assertive community treatment, more time for the needy patients. And if we lose that capacity with prescribers needing more and more training, then 42 doctors in the state of Pennsylvania will not be able to handle this epidemic. So that's a concern, is taking away the ability for more prescribers to help this medication. Like Dr. Warburg said, you can't overdose on buprenorphine, and I would much rather have 10 strips of buprenorphine circulated on the streets and diverted than 10 bottles of methadone, 10 bottles of oxycodone. That, you know, I'd rather give it to somebody who uses it for 2 weeks and looks better for that 2 weeks than to hold it back or have no one have access to it and more people just die. So we have to make sure that there is access to these medications through the proper physicians.
All right, so I think we're kind of nearing the end of our time. Just one last check that we haven't, maybe have some questions from the audience. Everybody's looking down at their phones. Okay.
I want to let me thank our elected officials and the staffers that participated in today. And I know we've had some people going in and out of the room, but know that we are here and that I will make sure that these presentations are made available to you, that the contact information is made available to you. And I want to thank you for what you do, and as you get educated on issues, and it's not just the epidemic, the opioid epidemic that you're dealing with. There's many issues that you're dealing with, and so we want to be a resource for you to be able to answer your questions, to let you know that the laws or the legislation that you or your bosses are writing and implementing, how that's going to impact the communities, the community. And I see us, working together. I think some of the common themes that I heard today as I was taking some notes, and it was the same thing. This is a disease. We need to be addressing this epidemic as a disease, and I think all our speakers spoke about that. We heard from the young individuals that were here with us earlier about how they are approaching it and helping developing an app and trying to work with their friends, family members, colleagues to educate them on this, and I look forward to that rolling out of that app. We also heard from how the footprint of Trinity Health is working together and how we can learn from each other. I have colleagues across the 22 states and want to bring those resources to Pennsylvania on what is working in those states and how we might implement those regulations, programs within Pennsylvania. So know that we have that robust approach here at Trinity, or Trinity has that remote approach to that. How in the Southeast there are some collaborations with the medical societies and resources, and how we might be able to continue to work together and work with our colleagues across the state to share some best practices. Education and awareness is important. I took a list of a lot of the legislation that was out there at one point. I think I'm hearing another one that probably was not initially on my list, at the Senate Bill 1054. I think I stopped at 1052. So as you know, legislation keeps getting introduced. I think at one point I took an inventory, there were 45 House pieces of legislation, 35 Senate, and I'm sure that's growing each day when we talked about this. So we want to be a resource for you. We know you have to deal with a lot, and we recognize it's budget time. I think we heard about care coordination from a couple of our speakers, the assertive community treatment, the ACT, and again, how that is important. But I keep coming back to a team approach, and not just in one organization, but as our communities need to come together to work together and get over the stigma that this disease and this epidemic brings, and that it's happening in all our families. There's somebody that has been impacted by this, maybe by a death, or somebody who's successful in recovery. So I just want our work to continue together. And before I forget, I want to thank Dr. Consuelos for helping me facilitate today's program. I hope I covered everything. I don't know if there's any last minute remarks from anyone, but I want this dialogue to continue. And hopefully we will have some productive conversations and legislation that continues to combat this epidemic.
And thank you, Kathy, for putting together.
Thanks.